My name is Dr. Jessica Moreno. I'm an assistant professor in the counselor ed program for the Marriage, Couple, Family Counseling program. I'm going to talk to you today about my dissertation research that I completed at Loma Linda University in 2014. At the time, the Affordable Health Care Act was going to be approved. It was in the process, and so what we did was, it was an evaluation of an adapted dialectical behavioral therapy program at Kaiser Permanente in Montclair, California. What we wanted to do was start to look at group therapy, how marriage and family therapists could deliver the services, and how the Affordable Health Care Act, because at the time there was going to be thousands of people that were going to have access to healthcare that never did before, and so healthcare organizations like Kaiser were going to have to start offering more group services than before. So this was an evaluation of the program, of the DBT program, and what it aimed to do was help patients that were repeat offenders. So what was happening was these patients that come, they would have alcohol and other drug problems and personality disorders, namely probably borderline personality disorder. And so they would come back and start reusing the services. And so what we wanted to do was see if we can get them all the way through the program, because these patients were showing higher levels of self-harm, suicidal ideation, alcohol and other drug abuse. So it was a 4-phase program, 20 weeks, 4 phases, 5 weeks each. It started with mindfulness and it went all the way through interpersonal effectiveness. So it was modeled after a private practice model of DBT to treat the individual within context, if you will. So what we found was, after the first phase of the program, patients were dropping out. They had 5 weeks of mindfulness training. We called it the mindfulness high, where they would come in, they would learn all these skills, they would start to feel better, they thought they were cured, and they would never come back. So, but then a couple weeks, maybe 10 weeks later, or the next cycle, they would want to come back to the program because they figured out there was more that they needed or that it didn't work. We were able to track a few patients from beginning to end that actually made it the entire 20 weeks. And what we found was the patients were reporting that suicide was no longer the answer. So the implications then were that if we can get patients at least through the 3rd phase, or at least through 16 weeks, that they will no longer, or at least report that they no longer want to harm or kill themselves. This research could be useful for program evaluators coming from in a systemic lens through a collaborative and systemic approach for evaluation, for evaluators to use both quantitative and qualitative research means. This could be good for organizations such as Kaiser, so that we could do a needs assessment like we did with seeing that there was a problem with this recidivism rate, implement the program, evaluate the program, and then come back with these results and recommendations of how to improve the program, or at least show the data to get these patients through. So we have the organizational piece for Kaiser. We also, for marriage and family therapists within medical settings, because at the time, 5 years ago, or traditionally, it was social workers that could be within medical settings. So then now we had a rationale to say marriage and family therapists can belong within medical settings. Also, program evaluation within medical settings. I think now that I teach up-and-coming counselors the importance of the dialectical behavioral therapy, because traditionally, therapy started out within private practice, but now we've moved on from the therapy room to these larger organizations. So how to take these preliminary theories, conceptualize and apply them to these group settings, maybe within like group settings, but also field organizations. If you go into the field, the different settings that the counselors may find them in, and also the different techniques of an adapted DBT program, and how to implement those within practice for their clients or patients. So my doctoral program, I didn't go through a traditional PhD program. It was a doctorate of marital family therapy. So the emphasis was on consultation and organizational research. So like I was talking about with how to implement a study within an organization, I could, like maybe a psychologist or another field, could treat an organization like an individual, where I recognize the individual as a patient, or as one person, if you will, do a needs assessment to see what's wrong, implement the treatment, find out the results, quantify it, and then come back with recommendations to make the program better, not necessarily change it, but make it better. In contrast to an individual where you could do your assessment, do your treatment or your therapy, develop your treatment plan, and then in the end, come up with your results to see what happened on the individual level. This is on a grander scale.